And so, as you know, guys, we had a session like this 2 weeks ago with Dr. Stan Vermund, who's the Dean of the Yale School of Public Health. Howie, who's also the School of Public Health, is actually everywhere. So Howie has almost every degree you can have. So he's a radiologist. He teaches at the School of Public Health, and he teaches at the School of Management and does the Executive MBA program on the healthcare track. And he is also at the School of Medicine. So he is a very busy guy. And he's been very generous to me with his time and with his students. I think 2 of them are on.
I've seen them.
Nisaker and Garrett, I think, are on this call. And, you know, he's been great for us. And I see him all the time, either being quoted somewhere or on Twitter. So he's much, much better than that other famous Twitterer. But he's been Twittering a lot lately. So anyway, with no further ado, I'd like to thank Dr. Howie Forman, and he's gonna talk to us about, I think he probably by now has a stump speech. And
yeah, I mean, I can
questions.
So I can go off in different directions, but I think just to begin with, I'll just mention a few things. You know, we're still just 5 months into this. Anybody that tells you that they know everything about this or knows how it's transmitted or what the, you know, what's truly safe or what's truly risky is sort of going out over their skis. I think all of us try very much to synthesize what evidence we have at the moment, but we also have to be cognizant of how much that's changing in real time, and we have to factor everything in. Having said all that, we're getting a lot better understanding about how this is transmitted. We've seen that certain interventions work very, very well, and you know, it becomes illogical to believe that there's some confounding factor that's causing it. We believe, for instance, that mask wearing works, not so much that it prevents you from getting infected, although it may in fact help you there as well, but it certainly reduces the risk that you will spread symptomatically or asymptomatically to somebody else. We know that the virus is likely transmitted through you know, your spit, through your speech, and that's why when people talk very loudly in closed settings, there's a much higher risk of spread. It's why we're seeing greater spread in church and temple settings, why we're seeing greater spread in bars, you know, loud bars in particular, where people are talking very loudly in small closed spaces. And it's why we're seeing very little spread out of doors. And it's not to say that there won't be spread out of doors. There certainly will. It's just a less likely way of spread occurring. We also know that the spread through surfaces seems to be less than we would have thought. At the beginning, everybody was much more concerned about that. That seems to be a lesser means of spread. It does not mean that you shouldn't be cleaning up. The first thing I do when I go in as a radiologist to work in my area is clean the space. So I don't want to make you convey to you that I think it doesn't occur on surfaces. It's just a lot less scary than people thought it was. I don't think, for instance, that touching an elevator button or touching the handle of a door is particularly risky unless someone very recently touched it with presumably a wet hand or coughed on it. So there's a lot of information that's just coming along as we go, and it's going to take time for us to get more and more of these answers. We do think, for instance, that the summer months reduce spread. Some of that may be because we're more outdoors, but some of it may also have to do with climate, humidity, the temperature, the sunlight, factors like that. So I say all of this because I think these tie into many of the questions that many of you have. What I'm going to do to start off with, rather than keep going like that, I can come back and tell you a lot more about where we are in the outbreak. I can tell you a little more about what I think about vaccines, but I'm going to go through your questions that you've given me in advance so that I make sure I cover that. I'm going to also allow you, as soon as I finish that, to start raising your hand, either physically or using the hand raise feature if you have that available to you, or just shout out. But I'm going to start with these. So what do you think the summer, fall, and winter will bring if you were a betting man? I am not a betting man, but I do think that our best objective as a nation right now should be to get this down as low as possible, because I do think that the fall and winter will bring a worsening of whatever we have. Again, that's basically making a calculated analysis based on what we know at the moment, and we don't know a lot. So that's what I think will happen. If we found ourselves in the fall and we're just muddling along just like we are in the summer, that would surprise me, but it wouldn't be so surprising to say it's impossible. What should hospice employees do or not do when they are not on duty in terms of going out in public? So, you know, we're going to all have to make calculated choices about how we live our lives in this period of time. It's possible that we're going to live the rest of our lives with a pandemic like this in some way, shape, or form, and that we're going to have to acclimate to that. And so what I would just say to you is think about everything you do as having some degree of risk and try to mitigate the risk as much as possible. I think to say that you're not going to go out again for the rest of your life would be ridiculous. To say that you're not going to participate in family functions and gatherings would be ridiculous. But I do think it's going to be, I personally would not go into a very crowded indoor function. You know, a typical wedding that we might have experienced a year ago, I think is going to have to be carried out in a different way than we would have done in the past. I would not be going into a crowded casino right now. That's just not what I would do right now. Although in 6 weeks, we may have enough information from the opening of the casinos in Vegas to tell me that there's less concern than I think. Maybe the high ceilings that are in place in casinos are less of a concern. So we're going to have to watch and see how that plays out. And I think that you're going to find that every single thing you do comes with some heightened risk. The thing that reduces your risk is decreasing your mobility and not interacting with anybody. And that's just not how we're going to be able to live our lives. There are some people that have very high risk profiles that probably do have to do that. But in general, if you're below the age of 70 or even 75, I think there's a calculated risk you can take. And to do so without feeling that you're putting your life at undue risk at this time. What should our travel plans include or not include over the next months? So a couple of things to keep in mind. Right now, we're at a very low incidence in the community, or low prevalence really in the community. There's the positive rate in the state of Connecticut, I think, is now below 2%. The positive rate in New York is going to dip below 1% very soon. And that's positive rate of PCR testing in a community that includes a lot of symptomatic individuals. So when we're down at those low levels, it gives you some insight into the fact that there's very low prevalence in the community, maybe 0.1% for real. So this is a time when going out and doing things is lower risk, and traveling is also going to be lower risk than it would be if the prevalence in the community was very high. Right now, most airplanes are masking, they're cleaning vigorously, they're keeping middle seats empty in some cases. Those things make air travel lower risk than they would have been in the past. I still think traveling in a tube that's self-contained is probably not one of the safest things we can do, but I think that we're going to get answers to that very soon as well. And for the most part, I think it's probably going to become something that we tolerate the risk for when we have to travel by air. Traveling by car is very different, and I think then you're taking on very similar risks that you are in your own community, and I don't think there's as much of a concern about that. How should we use volunteers going forward? So, you know, again, this is all about calculated risks. It's all about how much you, you know, feel comfortable yourself. I don't think anybody should force a volunteer to do anything. And so I think volunteers are volunteers. They're always volunteers. But I would think that volunteers that are under the, you know, definitely under the age of 65, and I think that you have to allow people to make decisions even if they're under the age of 75. I think above 75, you're probably taking too much of a calculated risk to warrant doing something at this time. So that's my answer to that, although maybe you had a more specific question that I'll take going forward. Would you treat those who have already had it as immune for testing purposes? If what you mean by that is, would you not have to test somebody who has had verified coronavirus? Yes, I would. I would not be retesting somebody who already had this, who had it verified. We do know that they will continue to shed in many cases for as long as, I think, 52 days, maybe longer. And it seems like a waste of both resources as well as increasing confusion to continue to test them. We now have sufficient series to know that there has never been a case of spread from somebody who is continuing to shed virus or virus particles, but who is no longer actively infected. We've seen no spread from those individuals, so that seems like a safe bet. And then last question as the beginning, why do you think the percentage of deaths in nursing homes in Connecticut is almost twice the national average? So without breaking out the data completely, you have to assume that it's tied into all of the comorbid factors, the ages, and so on. We know that the death rate for people in their hundreds has been very, very high for people in their 90s, much higher than 80s, and 80s much higher than 70s. We know that people with hypertension and obesity have had higher death rates than those without those factors. And so without knowing more, I'm going to presume that those are the factors that influence most heavily why Connecticut nursing home residents may seem to have a higher death rate than nursing home residents in other places. So I'm going to stop there and take questions. I'm just going to look at the participant list if anyone does want to raise their hand, or if they want to shout out, or if they want to physically raise their hand. Anything like that is fine with me.
So before I get them to ask questions, Howie, I think I'll ask you a few because I was the one that wrote those, so I can probe a little farther. I guess, so one of the questions is, in terms of the choices people make, I guess the question was about specifically, one of the things I'm specifically interested in is you obviously are seeing people all over the country protesting in large groups. Do you feel like if someone in your family went to a protest that you should do anything differently? So you're making your own choices, but the people around you are making different choices, and how do we handle that?
Yeah, I mean, it changes the risk profile a little bit of that individual when they do something, but that's not just protests, it's anything. So, I mean, I would say I didn't participate in a protest, but I joined a White Coats for Black Lives, I don't know what you call it, but rally or whatever at the medical school where several hundred physicians joined and stood at what we would consider to be social distancing, but it certainly wasn't 6 feet. It was probably about 3 feet. And I think most of us felt that it was a calculated risk. It is a risk. There's just no question that there's a risk associated with it. It's a calculated risk. Based on what I understand about how this is transmitted, I do not believe that my risk was significantly changed because nobody was shouting near me. I had a mask on. Everybody around me had a mask on. Literally everybody had a mask on. And it was outdoors. And those factors to me make it about as safe as you're going to get. But being around more people, definitely, and they were all physicians who are all being tested constantly at this point. We're finally all at the point where if you're symptomatic, you're definitely being tested. And all of us over the last 2 weeks were offered asymptomatic testing, not just offered, but encouraged. So you sort of know what you're dealing with there. I do think, though, that if somebody comes home to you and has participated in a rally where people were not wearing masks, where a number of people were in very crowded circumstances, if somebody was arrested and carted off in a enclosed container, that's a real risk. I mean, that would get me more concerned. That person should self-isolate for at least 10 days and get tested. So that would be my recommendation in that situation. But everyone is different.
Okay, and in terms of another thing I've had questions about, swimming in lakes and oceans and pools. And there are two parts to that question. One is the actual swimming, and the other is beaches and, how close people are together in those places.
My sense, I feel like the media has done a disservice there by focusing too much on that. I would be really shocked if there's spread going on there. Now, is there spread getting to the beach? Is there spread happening in a bar that's adjacent to the beach? Is there spread at a restaurant at the beach? That could be. But outdoors right now, the amount of spread that we can, confidently explain that's occurring outdoors appears to be really, really de minimis, really rare.
And presumably, as I've heard, pools anyway, chlorine would probably block any transmission.
Yeah, certainly if you're infected and you spit in the pool, it's impossible to imagine that fluid is going to infect you. That I don't believe can happen. Now, if somebody's in the pool talking to you like this, and they're obviously not wearing a mask, and they're shouting, so they're spitting, is that a way to transmit? Absolutely. Like that would be a way that you could transmit even though you're outdoors, because you're not wearing a mask, you're very close up when you're talking in the pool, you're talking loudly. That I can imagine spread occurring.
Okay, and so one of the questions I sort of have to ask is if temperature is better and we're seeing less of it, why is the Southwest and the South seeing more of it?
Yeah, so first of all, we don't know that it's temperature, that it's humidity, that it's climate, but I will say there are some people that have made the correct hypothesis that this is the time of the year in Arizona where people, and Texas, by the way, and Southern California, where people go indoors more because it's too hot to be outdoors. And so one could, and I'm not saying that we have any evidence of that. That's just a hypothesis that does make a little bit of sense, and that it may be the case that in Arizona, up until 2 months ago, being out of doors more was a lot more comfortable, and right now you just have to be indoors more.
That's an actually very interesting idea. I hadn't thought of that. Are you a proponent of vitamin D as a protection?
Unless you're going crazy with it, it can't hurt. And there are people that have made some cases for it. There's not enough to say that everybody should do it, but I certainly wouldn't discourage somebody.
And have you seen, other than so there was an interesting article in this week's New Yorker about Iceland, eradicating the disease. And of course, Iceland does contact tracing just to make sure you don't marry your cousin, and they only have 365,000 people on the island. And New Zealand, which is substantially bigger, but at 5 million is still a relatively small population surrounded by ocean. Do you think there are any lessons we can learn that would actually be practical to reproduce in the US?
Yeah, testing. I mean, I'm a huge proponent of testing. I believe that if we don't get a vaccine, number one, hope for the best, prepare for the worst. Hope for a vaccine, hope for the vaccine that works, hope for a vaccine that's scalable and all that. But if you can't have a vaccine, or if we don't get a vaccine, testing is equivalent to a vaccine. If I could provide you with a $5 or even $10 instant test for the coronavirus that was highly sensitive, that you could do in your facility every day, you would basically eradicate this and have no problem of spread. And if we did that on a wide scale in the United States for a period of time, we would stop this.
So do you think workplaces are transiting? I guess my question about volunteers had a lot to do with the fact that, so we did a lot of things when the government started locking down. We were exempt because we were a healthcare, essential organization, but we reduced our time in the building if we were not direct care workers. We went to wearing scrubs, which in retrospect, I don't think really mattered, except it reminded us to wash our hands a lot. We eliminated all volunteers so as not to have density in the building or increase their risk. And we just put in a lot of measures. I mean, we've now done a lot of testing, but based on the testing we've done, the little bit of COVID we had at the beginning seem to come from people at home in families,
Yeah.
and there's been, knock on wood, less of it since we started testing. So, and since we started taking COVID. So we've tested 75 people or whatever since we started taking COVID positive people, and we've had all negatives. So, what would you make of that?
Again, I think it depends on how much you rely on your volunteer army versus how much they're there, in excess of what you need. If you tell me you need them, then I would be using them. But I think that testing is the way that you mitigate that. Now, you may not be able to do that full throttle right now. You may have to rely on certain volunteers. Maybe there are volunteers that have already been infected, and therefore you can use them to start with. But I'm still very optimistic that sometime in the next 6 months, irrespective of the vaccine, that we will have testing that is scaled up and cheap enough that we can give everybody a test when they need it, so that you would know reliably that whoever's coming into work today is negative.
So we obviously, like a lot of places, shut down our our visitors basically, and we eliminated all unnecessary people from the building. Our volunteers actually are necessary, even according to Medicare, they're necessary as a condition of participation, although that's been waived for now. We have a lot of positions in the building that are not close to anything, on the second floor. We are allowing people now to come back by their choice. We're also starting to ramp up our hours in the building. We're all trying to limit ourselves to 20 hours in the building, some of us with more success than others. But we were trying to do as much as we could just to have less density in the building. So for instance, for senior management, we went back to in-person meetings this week, twice a week, but outside. So, what we've done so far has been working. We terribly miss our volunteers. And it's true, it's their decision. Some of them won't come back. I guess we believe that in a lot of parts of our building, the risk is no greater and probably less than if you went to a grocery store, because we're all so careful.
I think also remember that where we were 3 months ago to where we are right now, we all behave differently. We all take this more seriously. I go nowhere without having a mask. I have masks in every pocket all over the place right now. I mean, it's just like, it reminds me in a way of when I got a dog. Before I had a dog, I never carried poop bags with me. Now I have poop bags in every pocket of everything that I have. There's your dog walking by, just as I say that.
And no poop bag.
Yeah, no, but I mean, I feel like that's a cultural change that happens with all of us. I haven't even reached, I had a dream this week that I reached out and accidentally shook somebody's hand. I had a dream about that. That's how long it's been since I shook somebody's hand. And I imagine I'll never shake a hand again in my life. So I say that because I think that the risk profile for what we're doing now, if you brought people back, is very different than what it would have been a few months ago. And I think that if you say to your volunteers, like, are you home with somebody who could be a high risk profile, in which case let's get you to be tested more frequently, I think you can do things that make that work. We're going to have to figure out how do we live in this new normal.
I have a question.
Yes.
Joan.
I'm the volunteer lady, and I've been talking to Barbara about those questions. I've had a lot of questions about this controversial asymptomatic. And a lot of them are following the news, and they're wondering, can I bring it home to my mother? And testing is the answer to that. But I know that there is a controversy about what that means. And I think there's a lot of people very afraid. And that's why, they're very afraid to come back. And I think that age range of 75 and up is a lot of our volunteers. So, but I wanted to help answer that question for them.
Yeah, so let me say this. I believe that the physician at the World Health Organization who made that statement was misinterpreting her own data, and we are all convinced that there is asymptomatic spread. We are convinced about that. in general, what we mean by that is a combination of pre-symptomatic and truly asymptomatic spread. There is less evidence about truly asymptomatic spread. There's one case I know about from China. I'm sure there are many others, but it's certainly those are very infrequent. But pre-symptomatic asymptomatic spread is different. What that means is that with everybody, there is a 2-day window before you develop symptoms when you are typically shedding virus. And according to every model we know about, you are infecting people during those 2 days before you develop symptoms. That pre-symptomatic asymptomatic spread is very concerning, and it's impossible to know whether you're infected or not. So the assumption should always be at any given point in time that I might be infected, I just may not have symptoms yet.
Okay.
Now, it probably is the case, I'll come right to you, it probably is the case that people that never develop symptoms have a lower risk of transmitting. That's probably the case, but it's still no risk of transmitting. Yes, Mr. Sacco.
Go ahead, Joe. Oh, you're trying to unmute yourself. I think Evelyn may have to unmute you, but somehow Joan managed to do it. It's up in the upper right-hand corner.
Here, Barbara, I just unmuted everybody just to make it quicker for
Okay.
Joe, instead of trying to find him, because Howie's got quite a crowd on this call.
All right. Well, it's still showing that he's muted, though,
It
Evelyn.
may be that he has himself.
It sounds like I'm off of mute now.
Okay. Yeah. Now you're off of mute. Yep.
So, unfortunately, I have 3 or 4 questions. I don't want to hog your time, but you said some very interesting things. So not necessarily in order of importance. You talked
Howie,
about
he's
masks.
our medical director, just so you know.
Sure, doctor. Yep.
Nice to meet you. So you, in referencing masks, you talk about they're particularly helpful in terms of preventing spread from people who are infected to those who aren't. And so does that mean they're less protective if you're not infective and walking around wearing a mask? Is it helpful in terms of protecting you from people who are shedding virus?
So
number 2 is, so I'm the person who's been doing
Let him
all
do
the
one
testing
at a
here.
time, Joe. Let him answer one at a time. So
I'll
he doesn't have
answer
to
really
remember.
I'm feeling
quickly.
pressured to get all the questions in.
No,
we'll
you'll
come
still
back.
get all your time. But I would say that, you know, the graphics that I've seen, and nobody knows for sure, but the evidence is that wearing a mask probably protects you a little bit in the same way that nobody can be spitting in your mouth. But it's not, as you know, an N95 mask filters out 95% of particles. A cloth mask is probably more like 50% or even lower in some situations. So there's no question that when you're dealing with aerosol, a cloth mask is not going to be protective of you with a high degree of certainty the way an N95 mask is. But it does slow down the amount of spit that you're putting out into the air. And you know, I tell people that when I saw a Broadway show about 30 years ago, I sat in the second row one time. It's the only time I ever sat that close. And I got to see just how much spit is coming out of the actors' mouths every time they speak. And once you see that once, you understand why masks work.
Okay, thank you. So I've been the person who's been in charge of testing people at Connecticut Hospice. Our test kits have come from the Connecticut State Public Health Laboratory, and they've been hugely helpful with us and are doing free testing. The swabs that come with the test kits are like regular Q-tip swabs. The ones that come from Quest are actually much sort of narrower and tapered, but they have not been available. I check every couple of days, they're not available. So the thicker Q-tip type swabs are much more uncomfortable when I put them into people's noses. And I'm just wondering, you know, and I don't want to hurt anybody, so, you know, the swab and the reliability or the sensitivity of the test, because as I say, some people are able to tolerate it better than others.
Yeah, there's starting to be more and more data about which swabs are better and whether you go mid-turbinate or true nasopharyngeal or just nasal. As I think you know, the saliva testing is turning out to be really sensitive and obviously a lot less intrusive. So this is going to evolve over the next few months right in front of us. And, I had the much
Go ahead.
narrower one that you described. I had that done to me last week at the hospital, and it's much less uncomfortable than a typical nasopharyngeal swab from the past.
Right. So the instructions from the public health lab ask you to do a nasopharyngeal sample to the extent you're able, but I did see the data out of Yale suggesting that saliva was more reliable. So I wonder if I should just be putting it in people's mouths and soaking it with saliva and using that
Well,
instead.
so I'd have to go and look. I don't know how they did the saliva test, but I think you have to actually get a large enough sample. So that's what I don't know the answer to.
Okay. Another question is that the sensitivity data is frightening. A recent study showing that when people are in the prodromal phase, that the sensitivity is as low as 0 on the first day of infection and gets no better than about, I think it was 80%. Is that actually true? So can we rely on our tests, or should we be repeatedly testing people?
Yeah, so we use 70% in the models that we run, and we know that that means that if you do 2 tests within a week, you're getting up to probably 91% sensitivity. It is absolutely, like, if somebody has symptoms, they should absolutely be isolating whether the test comes back negative or not.
Okay.
And there's some people that say if you have symptoms, don't even get tested. Like, why waste the test? Just isolate as though you're infected, because that's what you should assume.
Right.
On the
And,
other hand, it's the asymptomatic contacts of people that if we can test somebody who's asymptomatic and find a positive case, we've had a huge impact. And then if you're missing 3 out of 10 or 1 out of 10, that's not great, but it's better than missing 10 out of 10.
Right. And the last question I had was, you mentioned obesity and hypertension as being risks for more severe COVID disease. Does that include people who have well-controlled hypertension?
It's a good question. I don't know the answer to that. Don't know the answer.
Okay.
I mean,
Thank you.
I will say, I don't know that anybody knows the answer well at this point, because the way we're capturing these comorbidities is typically, do you have a history of hypertension? It's not whether you have hypertension on admission, it's whether you are a hypertensive. So,
Right.
but we don't know the answer.
I actually read an article within the last couple of days suggesting, weirdly, that people on a certain kind of
Yeah.
inhibitor, ACE inhibitors, actually do better on ventilators.
Which ironically, the ACE inhibitors, originally they said, I mean, and this is a scary story to tell. Early on, ACE inhibitors, we were told that they're associated with worse outcomes, and Yale was on the cusp of telling people to go off ACE inhibitors and switch to other antihypertensives. And literally 8 weeks later, we have exactly the opposite view, that it's protective. And therefore, if we would have been taking people off, we would have putting them in harm's way in a multitude of ways.
Thank you.
So I have a
Thank you.
question, which is, I'm curious, when I know you advise governments on public policy, what does that mean? Does Trump call you up and ask you questions? I mean, what does it mean to advise the government? It suggests that the government has a plan or a controlled, set of questions.
I've only been helpful to state governments during this time. There are people, we have had a letter that we gave to the chief of staff to the vice president, and we are confident that the current vice president did read that brief a couple of months ago about testing. But I would say my influence in the current federal government is de minimis. But if you want to influence the Biden campaign, there I can help you a little bit.
So what have you told the Biden campaign that you can share with us?
Oh, everything I'm saying is public. I mean, I've been very clear. They know my view on this. And I think if you look at the Biden plan right now, it's very close, or if not identical, to what we're suggesting, what I'm suggesting.
So are there states, I mean, how do you think Connecticut stacks up in terms of the states that are doing it right versus the states that aren't?
I think Connecticut's doing okay. I have said to the governor's office since literally like the first week of us having legitimate cases in the state that we had to ramp up testing. And for reasons that I won't go into, they haven't been big fans of testing until it was much later. We are now testing at a rate that I think is above the national average and certainly appropriate to our level of outbreak. It would be, we should pretty much still double from here our testing. And if we could do more than that, even more so. I think one of the challenges is that some employers are starting to hoard capacity. They want to bring people back online, and they know that to bring a factory back online, they want to do a lot of testing. So they're actually hoarding capacity until they get the moment to open things up. And so I'm hoping that we're going to see a lot more testing in a few weeks.
So how often do you think we should be testing at Connecticut Hospice?
It's a good question. You know, for Yale, if and when we open up at the end of August, we're going to probably be testing every week. It would be, you know, if you believe that every week testing is appropriate for students that have a very low risk, have to say that testing at least that level is what employers should be aiming for. Major League Baseball is testing, I think, twice a week. The NBA may even be higher than that. The White House seems to do it every day. You know, testing is, it may not be a direct linear relationship, but there is a direct relationship between the amount of testing you do and your ability to tamp down the outbreak. So I would do testing once a week if you have the capacity to do it.
So, Dr. Forman, it sounds to me like the utility of testing is that you can quickly move people out of circulation for 2 weeks,
Exactly.
so they don't spread the virus. Is that the case?
Yes, and people don't think it has to be 2 weeks, by the way, but yes.
What do
Okay.
they think it has to be?
There are a lot of guidelines that are moving around. There's some that basically say that that a week after symptoms are gone and no fever, you could be back at work. So there are some that say you could be back sooner than 2 weeks.
Another question I have about testing is, you know, I mean, we can't mandate testing. Are they mandating testing at Yale, or is this voluntary?
I think for the students, it's going to be, I think there is a way to mandate it. I think you can make certain things contingent on your being able to participate in activities on campus. I think that from a public health point of view, you probably could mandate it for your employees. I don't know. I don't follow employment law. But you know, I would be doing everything I could to get people to test as often as you can. And I would try to do saliva testing so that people don't feel like it's an imposition on them.
Right.
So
I mean,
we've been having
certainly
people take their temperature twice a day for the last 2 months.
But we don't know that works at all. Like that's a frustrating thing. They tell us that as well. There's practically no evidence about whether temperature taking has a meaningful impact. Most people, by the time they have a fever, have some other symptom.
I've been struck that the majority of our employees have elected not to be tested. You know, I would prefer not to mandate testing. I would have to speak to my colleagues to find out if that's even possible. But I sort of wonder why it is that, and this is not really a question, it's an observation. I wonder why it is that more people haven't come in.
I happen to believe it's because people totally don't get what testing's for. I just believe that. They believe that it's to diagnose somebody with symptoms. And I think a lot of us have a tremendous amount of confidence in our bodies and believe that if I feel fine, why would you need to test me? I had a perfectly busy day today. Why would you want to test me? And if you don't understand the pathophysiology of this particular viral illness and the epidemiology of its spread, then I would look at you and say, why do you want to test me? This is the most uncomfortable thing possible. I don't need to do that. I'll tell you when I need to be tested. But if they're educated about why this is a very important public health matter, and you know, I don't want people to be stigmatized by this, but I want people to feel responsibility. If somebody said, like, you know, I said I didn't want to be tested, and it turned out I spread it to 8 people. That's a you know, a scar.
What about the idea that we're not testing everybody on the same day? So it becomes a sort of rolling testing. You know, like I got tested 2 weeks ago or 3, whatever it was, and I was negative and I still feel fine. But, and I understand if you're testing every week, it's one thing. But it seems to me that if you're testing hundreds of people, but all on different days, that it doesn't tell you much about what's going on. I mean, I've had people tell me we all have to be tested on the same day.
Yeah, I've only talked to larger organizations, and those testing on one day would be almost impossible. So for them, it's easier to say that, you know, Barbara's a Monday and Joe is a Tuesday and Mina's a Wednesday and so on. And then you know your day of the week. You come in on that day of the week, you get tested. We are able to actually track how many positive cases occur. And then when a positive case occurs, then you can actually do some serious contact tracing on that individual and pull in additional people immediately to test them out of cycle.
So it sounds like you are a fan of contact tracing.
When you have a minimal outbreak, and certainly in a small organization, contact tracing makes sense. I'm not talking about the sort of invasive contact tracing that South Korea has been able to do. I'm talking about that, you know, if Mina comes back and had a positive test and she had spent time in your office for an hour, I would want you tested.
Yeah, that we're doing. Okay, and also we did say, just so you know, Joe said we did say that volunteers who want to get tested, we can test. So if a volunteer wants to come back and wants to be sure that we can test them, because we have the kits and we're doing it pretty much every day.
Dr. Forman, another question. We in the past have had support animals in the building, which primarily are dogs. What are your thoughts about the risk they may present, and should we be testing them too? And is that
he
possible?
loves dogs, so he's going to vote in favor of dogs.
As far as I know, the last I checked, there has been no transmission from an animal to a human. There is transmission from humans to animals. I'm not even sure there's transmission between animals, although I think it's been surmised. I can't believe that there's a meaningful risk of dogs transmitting it.
Is that because you love dogs, or is it really true?
I think that we are all biased by our life experiences, and I would like to believe it's because it's true, but I can't swear that I'm not biased.
Okay.
Okay, are there questions from people other than me and Joe Sacco? Nina.
So, as a volunteer, if I'm only coming in once a week, if I'm tested the day I come in, or do I get tested a few days before, or what would you suggest that in that kind of situation where a lot of us will go in one day a week?
Yeah, it's a great question. I mean, ideally, we would get tested 2 days before and try to get as much yield as possible out of it. But I also think that a lot of what we're talking about in terms of testing is about, you know, some level of surveillance and trying to find cases in the community. And so if you came in and you were 100% asymptomatic and got tested and you turned out to be positive, we would then have to put in place all the other mechanisms that we usually do. You're going to be wearing a mask. You're going to be social distancing. The risk of you spreading it, even if you're positive, is going to be mitigated considerably. So I would not tell you what I think is the absolute way to do this, because if you told me you volunteer but you come up here from Westport, then I'm going to tell you that that's what you got to do. You just come up on the day of and you get tested.
Thank you. Now I'm on the footpath to the hospice, so I'm not coming very far.
And I think, like, if you want to really try to do it, I think 2 days before would be ideal, because if 2 days before you're negative and you come to the hospital and you still don't have any symptoms, then pretty much made it through that part of the window. Now, you could have gotten infected right after you got it, and then you could start to shed on the day that you show up, but that's a risk I guess you have to take.
I guess I would say that testing before you start back makes sense for your protection, once, and it makes sense for us because that way, if you did get it, we would know if you tested positive, we would know you didn't get it from us if you got tested on your first day, which is a big benefit when you're running a healthcare organization. But aside from that, I kind of agree with Howie. I mean, we don't really know people's individual risk profiles because we don't really know what they're doing and to whom they're exposed when they're not there. I think if you thought, like, your daughter came to visit and she was just yelling in a crowd without a mask and you thought you should be tested, you're probably right. Maybe you should be tested. But, ordinarily, I would say testing at the beginning, just like we're planning to make sure that people understand the use of PPP in different settings, it is helpful.
All right.
Thank you.
We have other questions?
Hope there's something in the chat. Let me just make sure.
Garrett has a question.
Yes, there are two questions in the
Yes.
chat.
So as far as mutations, we don't, the virus is constantly mutating, but the mutations that we're talking about are mostly non-clinically relevant mutations. Viruses mutate, and it doesn't necessarily impact its virulence. It doesn't impact other features of it. And so at the moment, none of the mutations appear to be relevant, and none of them seem to impede the chances of a successful vaccine being made. But that could change by next season completely. As far as how plausible an effective vaccine might be, I would say, if I had to bet, since somebody brought that up earlier, I would say there's probably a 50 to 80% chance that a year from now we'll have an effective, widely scalable vaccine out there. But that means there's something like a 20 to 50% chance that there isn't, for one reason or another. Are there any feasible long-term plans for testing in urban areas where the residents have logistical challenges? Yeah, I mean, we're actually, I think, doing, the state is, and nationally, we're doing much better of getting out to areas where there's higher prevalence in testing. I think that's a credit to our public officials and healthcare providers to have recognized that need. They did so a little bit late. That's why, not a little late, but very late. And that's why we've seen such incredible disparities in outcomes and disease in some of the most vulnerable populations. I think now we're doing a much better job with that. And the last question is more a political question. I think that, we've watched, our current president and others throughout the world trying to damage institutions both domestically and globally because they serve political ends. And that is, a shameful period in our lives right now. And I do think that we can repair this. I think it's going to be a lot of hard work, and it's going to take time.
So I have what's maybe a last question for you, which is, the question of that's arising for a lot of people of we're starting to emerge, and some of us haven't seen friends in a very long time, and the Times is talking about quarantine pods. But if I've been isolated for 3 months and you've been isolated for 3 months, it doesn't seem like a lot of risk for us to get together outside for dinner. But I wondered what you felt about that.
Everybody has their own risk profile, and I know people who have stayed home for 3 months, but their son has come and gone periodically. Our risk profiles are hard to know for sure. The more you open up the bubble, the more risk you're taking on. The good news is right now, the incidence of prevalence in the community is so small that, the risk profile for most of you is really, really tiny. If you look at where cases are coming from right now, there's almost none coming from the suburbs of New Haven, for instance. And even within New Haven, they're coming from specific neighborhoods in New Haven. it really is a virus that has dramatically disproportionately affected people in poorer communities.
Can I ask a quick last question?
Sure.
Reinfection. I think there's been some concern about that. You've been infected, you were sick, you recovered, you seroconverted, you have antibodies now. Is it possible or likely that you can be reinfected? And if so, would you actually get sick again, even if not quite as sick? And would you then be infectious again, or is there no data on this?
So there's no evidence of anybody being reinfected yet in the way that we're describing it. There are definitely people, as you've mentioned, the sensitivity of the test is so low that it's not that difficult for somebody to be positive and sick. They get better, we test them again, they're eventually negative, they go home, 2 weeks later, they start having a little cough again, you test them again, they have viral particles again. The virus never left them, and there were always little particles and then nasopharynx during that point. And so that's effectively a false positive, or it was a false negative in between. Either way, but the person is not reinfected. They just continue to shed dead virus particles for weeks on end for a period of time.
But we're still confident that if they are now 2 weeks from the onset of symptoms and at least 3 days from the resolution of symptoms, even if they subsequently develop some low-grade symptoms, that they're not infectious. They're shedding dead virus.
We don't have a single case of spread that way. And that's the only way we measure it now. And that could change dramatically in a few weeks. Somebody may come up and show a series, but like all we can do is rely on what we know for the moment.
Right. Okay. Thank you so much.
No problem.
This is Janet. Could you talk a little bit about antibody testing?
Yeah, so
antibody
You know, maybe people should mute themselves if they're not asking questions, because there is noise coming from somewhere.
Yeah, so antibody testing is actually very useful on a population level, and it's why right now we're about to undertake a study in the state of Connecticut looking at the prevalence or antibody positivity in the state of Connecticut. But it doesn't tell the individual very much, because the false positive rate for antibody testing is sufficiently high that if you test positive for antibodies, it's possible that that's a false positive, substantially possible that it's a false positive, and then you're putting yourself at risk when in fact you've never had the disease before and you think that you're protected. If it comes back negative, on the other hand, the sensitivity of antibody tests is high enough to tell you that if it comes back negative, you probably have not been exposed. So it does give you some information, but it doesn't give you the information most people are looking for, which is to say, I'm safe. There's no way that the antibody test right this minute as a single test can tell anybody that they're safe and secure and that they can go about their business. All right, I think we'll wrap it there.
If there are no other questions, I want to thank Howie very much for his time and expertise. And you can clap with your implement, or you can clap visually on the screen. But we're very grateful to you, and we hope that you stay healthy and happy, and that you and your dog get to spend a lot of time outdoors this summer.
We're looking forward to it. Thank you very
Safely
much.
distancing.
All right.
Okay, thanks to everybody.
Bye-bye.
Thank you.